Assalamu alaikum and good morning. I'm Khulood from Farwani Hospital. I'm going to present Interpreting Rheumatologic Lab. I'm going to focus mainly on the main labs that are ordered by physicians before referring their patients to rheumatologists. So we all know that the diagnosis of any disease, not only rheumatologic diseases, is based on clinical information, blood tests, imaging, and in some cases, histological findings. And the blood tests are useful in confirming clinically suspected diagnoses and in monitoring some of our diseases. The tests should be used as adjunct to comprehensive history and physical examination. So the test on its own doesn't mean anything to anyone. We should all know that the value of test in diagnosing a certain condition depends on the pre-test probability. So a positive test result with high pre-test probability helps to make the diagnosis. And on the other hand, a negative test result with low pre-test probability helps to rule out the diagnosis. So here we have two common case scenarios that we all see in our clinics on a daily basis that I'm going to present, and then later on I will come back to these cases. The first patient is a 62-year-old lady who was referred to rheumatology clinic with 1-year history of arthralgias affecting her hands and knees mainly, with morning stiffness that does not exceed 15 minutes. Her CBC revealed microcytic anemia, which is most likely due to the use of non-steroidals. Her ESR was elevated according to the lab preferences, but actually according to her age, it's normal. Her rheumatoid factor also was high, 40, and our normal range is up to 20. So she was referred to us with questionable rheumatoid arthritis. The second lady is a young lady, she's 32. She came with arthralgias affecting all over her joints. Her ESR was mildly elevated, 25, and her rheumatoid factor was upper limit, 20. Her ANA was positive though, it was 1 in 80. So the possibility of lupus was there when she was referred to us. So I'll come back to these two cases. In this presentation, I'm going to cover the acute phase reactants, rheumatoid factor, ACPA or anti-CCP, ANA, and extractable nuclear antibodies. So what are the acute phase reactants? These are proteins whose plasma concentration increases. So those are the positive acute phase reactants or proteins, or decreases, and these are the negative acute phase proteins by at least 25% during inflammatory conditions. Examples for positive acute phase reactants are C-reactive protein, ceruloplasmin, ferritin, fibrinogen, haptoglobin, and serum amyloid A. Examples for negative acute phase reactants are albumin, transferrin, and transthyretin. So what's the ESR? It measures fibrinogen mainly. It's one of the acute phase reactants. The fibrinogen is produced in the liver as part of inflammatory response and under the control of many cytokines. And examples for that are interleukin-6, interleukin-1, and tumor necrosis factor. Many other factors that affect the serum fibrinogen level or the RBC morphology can affect, of course, the level of ESR. So we have a huge list of differential diagnoses that should come to our mind when we see an elevated ESR. One of those is pregnancy, because it increases the fibrinogen level, so it increases the ESR. Anemia, because the plasma contraflow altered, can increase the ESR. Macrocytosis, because the cells fall faster, and that can also lead to higher ESR. Other conditions like diabetes, end-stage renal failure, malignancies, infections, and collagen vascular diseases. Women generally have slightly higher ESR levels than men. And personally, I don't care about the level that is given by the lab, because we have to calculate it according to the patient age and sex. So normal ESR for a male patient should be their age divided by 2. And if the patient is woman, we have to add 10 to that equation. ESR also can be affected by room temperature and laboratory technique. Being said that the ESR is not that specific, it's still considered to be part of diagnostic criteria for many rheumatologic diseases like rheumatoid arthritis, PMR or polymyalgia rheumatica, and giant cell arthritis. ESR can be also used in disease monitoring, especially in RA patients. Next is CRP. It's again another acute phase protein produced by the liver. It's directly measured by ELISA or nephelometry, so unlike ESR. The advantages of CRP over the ESR is that it rises and falls more rapidly in association with acute phase response. And it is not affected by any condition that affect the ESR, like anemia or renal impairment. Being said that, still, it's unclear if always more sensitive than ESR for various collagen vascular diseases. So sometimes we can see this in the clinic. There's a discrepancy between the ESR and the CRP level. And the reason for that, as I mentioned earlier, the CRP responds very fast, and it goes down very fast on the resolution of the inflammatory status. The ESR takes longer time to peak in response to inflammation, and again, slowly comes down. So that's actually leads to this discrepancy between the level of CRP and ESR. Okay, so next is rheumatoid factor. It's simply an autoantibodies that are directed against the FC portion of IgG. The most commonly measured one is IgM. Other rheumatoid factor subtypes are IgG, IgE, and IgA. So what about an RA? Rheumatoid factor has prognostic value. Mainly prognostic, so it's not of diagnostic value. It indicates that those patients who has positive rheumatoid factor are more prone to have severe disease. Those are difficult to treat patients, and they are more prone to have joints deformities, erosions, and extra-articular manifestations of RA. The titers of rheumatoid factor are not followed, so there is no value to repeat the titer of rheumatoid factor. Sensitivity of rheumatoid factor in RA ranges between 50 to 80%, and it has specificity of 85%. And please keep in mind that up to 25, so 1/4 of elderly population can have positive rheumatoid factor. So all these facts make the positive predictive value of rheumatoid factor poor in population with a low pre-test probability. Okay, so rheumatoid factor is totally non-specific for rheumatoid arthritis. It can be found in rheumatic conditions other than RA. Examples for that, cryoglobulinemia, SLE, Sjogren's, and scleroderma. The non-rheumatic conditions that can give rise to also elevated rheumatoid factor are bacterial endocarditis, infections. Commonest ones are hepatitis, tuberculosis, malignancy, pulmonary diseases like IPF, sarcoidosis, and silicosis, as well as in primary biliary cirrhosis. So next is anti-CCP antibodies, and these are originally identified over 40 years ago. And it is recognized by indirect immunofluorescence on the skin or epidermal cells. The target later identified as filaggrin, which is a form of keratin where the amino acid arginine has been modified into citrulline. And between the period of 1990s till 2000, it has been recognized that RA patients make antibodies not only to filaggrin, but to many proteins that contains citrulline. So facts about anti-CCP. It has a sensitivity of 70 to 80% for RA, which is kind of similar to that of rheumatoid factor, but it's more specific for rheumatoid arthritis. It has specificity of 95%. So it helps us to distinguish between RA and other rheumatic conditions. The presence of anti-CCP can also predict the onset of RA. In one study, it has been shown that up to 9 years. It has also prognostic value rather than diagnostic, because in the absence of signs and symptoms of RA, we cannot make the diagnosis of RA based only on positive anti-CCP. So next is ANA. ANA is the autoantibody directed against most nuclear antigens and the most commonly detected by immunofluorescence on intact cells. If the ANA screening is positive, then we have to go and ask for more specific antibodies directed against the antigens, so the extractable nuclear antibody. If it is negative, with a few exceptions like anti-Rho or anti-Jo1, then there is no need for other antibodies. ANA has sensitivity of 95 to 99 for lupus, but please keep in mind that it is only one of 11 criteria, ACR criteria, of the classification criteria for lupus, and it is also one of the new criteria, SLEC criteria for lupus as well. ANA negative lupus is rare, but it can be seen up to 5%. And please remember that the anti-double-stranded DNA is the more specific test for lupus, and this is the one that can be repeated to follow the disease activity. So ANA is not nearly as specific for lupus as it is sensitive. It can be seen in other conditions like autoimmune thyroid disease, other collagen vascular diseases, some medications like anti-TNF or antibiotics, infections, autoimmune hepatitis, and primary biliary cirrhosis. And if the titer is low, patient asymptomatic, this is normal in normal people. So ANA summary, the ANA testing is very useful in establishing the diagnosis of lupus. Nearly all patients with lupus has it positive. However, most patients with positive ANA do not have lupus because the prevalence of lupus is low in the general population. And the ANA titer, as I mentioned earlier, is not used for assessing the disease activity in lupus. ANA testing then should be reserved for patients with high suspicion for diseases like autoimmune disease. So if we see a young woman with rash, arthralgias, then yes, go ahead and ask for ANA. But if the patient is an elderly woman who comes with generalized body aches, I don't think it's worth it to do the ANA. Next is ENA. So we get a panel of 6 autoantibodies when we ask for ENA, or extractable nuclear antibodies. And these are the anti-Smith, which is very specific for lupus, like double-stranded DNA, anti-SCL70, found in diffuse sclerosis, anti-centromere in limited scleroderma, anti-Rho and La in patients with Zika symptoms, and in patients with photosensitive rash. Anti-Jo1, it is one of the myositis-specific antibodies, so an inflammatory myositis, and anti-RMP can be seen in patients with mixed connective tissue disease if it is in a high titer. If low titer is totally not specific for mixed connective tissue. So back to the first 2 patients, that elderly lady who came with positive rheumatoid factor, which is 40, little bit high ESR, but according to her age, her ESR, the normal should be 36, so she's fine. And she was having also microcytic anemia. On examination, when I saw her in the clinic, she has Heberden and Bouchard knots on the hands. The x-rays also confirmed my suspicion. Her pain was mechanical pain when I took history. So I made the diagnosis of osteoarthritis. The second lady, the young lady with arthralgias, fatigue, and positive ANA, mildly positive ANA, actually she was found to have hypothyroidism. Of course, I asked for more specific tests like ENA and double-stranded, and they all came back negative. So here is my take-home messages. The diagnosis of rheumatic diseases is based on clinical information, blood and imaging tests. The value of a test in diagnosing a certain condition depends on the pretest probability. We must all know that the qualities of all the tests we are performing, and the most important point here is to know that improper application of these tests lead to misdiagnosis, inappropriate therapy, and unnecessary healthcare expenses. Thank you very much.